And I have received peer-reviewed government foundation funding for work in this area. So MOV007's journey first started with a tale of two cities, Seattle on the left and Toronto on the right. I have a predilection to Toronto, of course, but Seattle was trying really hard to do science in this area. So it's two New England Journal articles. The Seattle group did the arrest trial with Pete Kudenchuk, and then the Alive trial was done by Paul Dorian at the University of Toronto. The differences between these two trials are best summarized in this very simple slide. So the arrest trial looked at amiodarone versus placebo with a lidocaine escape. So if you didn't get better in either arms, they rescued you with lidocaine. So it was a fairly complex trial. The Alive trial was amiodarone versus lidocaine. So the Seattle group did a complex trial of amiodarone versus placebo with a lidocaine rescue, and the Toronto paramedics did amiodarone versus lidocaine. There are also some very important differences. Seattle has a very high rate of bystander CPR. You can see it's 63%. Whereas Toronto, at that time of this trial, had a bystander CPR rate of 27%. Also, first shock was optimized in the city of Seattle. First shock occurred at 7 minutes after a 911 call, whereas in the Toronto group it was closer to 12. But both teams were unable to give the drug early. So both Seattle and Toronto gave the drug between 21 and 25 minutes into the cardiac arrest. So in time zero for this time interval was arrival at scene. So it's probably even longer if you added in downtime. Both trials' primary outcome was admitted alive to hospital. So it's a very short-term outcome. Both demonstrated an advantage with amiodarone. But the survival to discharge, neither trial was actually powered to look at this secondary outcome, which was survival to discharge. And it's for this reason that there truly was community equipoise, because there were a group of resuscitation scientists who felt that amiodarone, when given to a cardiac arrest or to a heart that's struggling, that it was toxic. And there was another group of resuscitation scientists who felt that amiodarone was the bee's knees and should be used in cardiac arrest. But in fact, the formulary excluded or did not mention cardiac arrest, so it wasn't actually designed to be used in cardiac arrest. And it wasn't proven in any country to be licensed for the use of cardiac arrest. Hence, the ROC investigators decided to do an amiodarone versus lidocaine versus placebo, and the focus of my talk is just trying to understand this large randomized controlled trial. A colleague would follow shortly after to go through all the antiarrhythmics, but this talk specifically will help you through, well, at least I hope it will, an understanding of this complex trial. So the amiodarone lidocaine versus placebo study is the ROC-ALP study done by the ROC Consortium, and it was published in the New England Journal of Medicine. Pete Kudenchuk again was the first author. This is an outline of sort of the trial itself. You had to have persistent or recurrent VF after one shock. So everybody who was in initial VF and got a shock and got better, they're not in this trial. The only time you got in this trial is if after one shock you went back into VF or you never came out of VF. You had to have vascular access for obvious reasons, and then you were randomized to one of three. This is a blinded trial, so the medic and the patient and the receiving ED physician were unaware of the drug given in the pre-hospital setting. Standard resuscitation measures were added, and post-cardiac arrest care was left to the discretion of the institution and the receiving physician. Primary outcome measure was survival to hospital discharge. The ALPS kits looked like this. Just wanted to show you it truly was blinded. And the dose is 150 milligrams of amiodarone, and patients who were greater than 50 kilos got 300 milligrams right up front. And then if you went back into VF again, so at the third or fourth shock, you could get a second dose of amiodarone or lidocaine or placebo. This is what the trial looked at. We measured and monitored 37,889 cardiac arrests, but of those, the kit was opened in 4,667 and the exclusions were over to the right. This was an intention to treat analysis, and in that population for the ITT, because we actually measured safety on everybody, but in the ITT population, which was pre-specified, we looked at amiodarone versus lido versus placebo, and you can see the numbers on the bottom. So the analytical population is about 3,000. You can see the exclusions are over to the right. When you do pre-hospital trials, it gets messy, because it's not very clear, the environment is chaotic, and bad things happen. So you can see the kit was opened in patients who the initial rhythm was not VF, or they lost eligibility, they were not in VF, or they, for some godforsaken reason, didn't give the drug, or there was some other reason for ineligibility. So that was the ITT population, and the modified ITT is in yellow. This was the analytical population. These were both pre-specified. You can see here in the baseline patient characteristics that they're fairly similar across all three groups, which is the purpose of Table 1. And you can also see the most important part here is the bystander CPR rates. Remember I showed you in the Tale of Two Cities the difference between bystander CPR, which also would have accounted for that huge difference in survival to discharge between Seattle and Toronto. But now and across all the ROC sites for the patients who are randomized, the bystander CPR rate is about 60%. Okay, the other nice thing about a ROC trial is that you have mandatory measurement of CPR metrics, so you know whether or not the resuscitations are equally provided across all patients. And you can see here in the amiodarone, the lidocaine, and the placebo group that all patients received high-quality CPR with good compression rates around 110, a compression depth of at least 50 millimeters, and the CPR fractions are tight. Look at the standard deviation, it's 0.09, so they're tight around 0.83. So this is highly optimized CPR, and this is good because you want to know that the drug actually gets you the answer you're seeing, not the fact that they just got better CPR. So everyone got high quality CPR in this trial. And if you remember in the Tale of Two Cities, Seattle and Toronto struggled to get that drug in between 21 and 25 minutes. In the ROC trial, and we pushed them hard. We were on them like a fat kid on a Smartie, trying to get that drug in as fast as we could. You can see we only dropped it to 19 minutes. So this is a big problem. It's very complementary to what Mike Donino just talked about with epinephrine. We're giving a drug 20 minutes in after the arrival of the ambulance that carried the drug. So it's probably even longer. The sample size, this big randomized trial, was powered to find an increase of 6% survival, and it had 90% power to do so. This lidocaine versus placebo and lidocaine versus amiodarone were secondary analysis, therefore it's not powered really. These were the absolute differences. You can see this is the primary outcome measure, and they all cross 1. So this is not a definitive trial in the sense of amiodarone versus placebo, libo versus placebo, or amiodarone versus lidocaine. However, the interesting part comes when you look at bystander witnessed. Pre-hospital trials, as I said before, are messy. Bad things happen. But the most important thing is we really don't know when time 0 is, so we don't know how long they've been down, and we are essentially comparing apples to oranges. When we tease out the witness group, bystander witnessed or EMS witnessed, we're now closer to time 0. and we're more likely to have a drug effect seen, and that's exactly what you see here. Amiodarone versus placebo, Lido versus placebo in the bystander witness group has an advantage of about 5%. In the EMS group, it's even much more powerful at 22%, but look at the sample size now. We've gone from 3,000 patients now down to 154 in this secondary or subgroup analysis. In the EMS witness group, it's important to note that lidocaine had no advantage over placebo, but this could be all related to sample size because now we're down to 97 patients. So what would I do? Would I give amiodarone? This is the current American Heart Guideline. Would I continue to give amiodarone to refractory VFVT based on the findings of the study? I draw your attention to the fact that the amiodarone in this trial is not an amiodarone that's actually sold in Canada. It's Nexterone. And the reason is because amiodarone, that group of resuscitation scientists that said amiodarone is toxic to a heart and cardiac arrest, attributed the toxicity to the diluent. In amiodarone, and the injectable form that's currently available in Canada and the United States, it's mixed with a diluent that causes hypotension. And so when given in a cardiac arrest patient, the post-arrest hypotension was attributed to this long-acting antiarrhythmic. And therefore, it was thought to be toxic. The Nexterone, which is the drug used in the ROC-ALPS trial, does not have this diluent. So, I can't prescribe or use the drug that was used in this trial on a routine basis in Canada. So I'm left with lidocaine versus old amiodarone as my choice. So let me put the numbers up there, and people love NNT, number needed to treat, so I thought I'd show it to you. So the Nexterone versus placebo has an advantage of 3% in the survival rate. We know that in medical futility, you should throw something out if it can't achieve more than 1% advantage. So Nexterone over placebo in all patients in out-of-hospital cardiac arrest had an advantage of 3%. We didn't have the sample size to show that that was superior, but you have to answer in your own situation where you work, is 3% important to you? Because it didn't achieve 6, but it was 3. And so if you think 3 is important, then the number needed to treat is 33. Lidocaine had an advantage of 2.6%. It wasn't 6%, so it wasn't clinically significant or statistically significant, but is 2.6% clinically significant for you. When you look at the witness cohort, now we're into an advantage of 5%, so you have to ask yourself, is a 5% advantage with either drug advantageous to me over placebo? And if you think 5% in the witness cohort is advantageous, then the number needed to treat is 20 for Nexterone and 19 for lidocaine. I just remind you that studies like this, which were transformational in terms of teaching us to give thrombolytic, had a number needed to treat of 91. So what would I do? Since I can't use Nexterone, amiodarone is not available in an injectable format, and using amiodarone in the pre-hospital setting is tough because you gotta mix it right there by the bedside, so it's very challenging for the medics. And it's $4.85 in the powder format in Canadian dollars. The lidocaine is $27.80. It's in an injectable format and it's easy to give. So what would I do? I'd probably stick with lidocaine in the pre-hospital setting. It's very hard to teach paramedics who rarely see cardiac arrest to differentiate between witnessed versus unwitnessed, and don't use anything in unwitnessed and give Nexterone in witnessed. I personally don't think that would be advantageous. We know from this trial that everybody in the unwitnessed group, there were no safety issues. So you could uniformly use amiodarone in the Nexterone format or lidocaine and universally give it across all out-of-hospital cardiac arrest if you wanted. You could look at cost, you could look at efficiency and ease of use, and make a choice of the other, and you'd be equally right, in my opinion. Thank you.